How are you, dear friends? Now we are going to continue our series of applied neuroanatomy, and we are moving from one section to the other. Now we ended with the peripheral nerves, and we'll start doing the osteology, the anatomy of the bones, and it's starting from above downwards. And the first thing we'll start about it is anatomy of the skull vault, the craniometric points and craniocerebral relation. Many of you would say that the skull vault is very easy as anatomy. Yes, but it's not only the anatomy. You have to know the craniometric points and the craniocerebral relation. So, in brief, the craniometric points are anatomical landmarks on the skull, helping to describe the relation of the brain to cranial bones. It's very important to have this relation to put your exposure, exact exposure in the skull to reach certain regions of the brain, and to put your burr holes to reach some regions in the ventricle. So the general plan of the subject we're going to talk about is number one, we're going to discuss the anatomy of the skull vault, which is the pure anatomy, sutures and craniometric points. We are going to discuss some neurosurgical points, which are points of relative importance to neurosurgeons, and we are going to talk about the craniocerebral relationship, and last but not least, the surface anatomy of the transverse and sagittal sinuses. When we start with the skull sutures, you all know that they are made of fibrous tissue connecting the bones of the skull together. And actually we have four main sutures of the skull. I mean the adult skull. In children we might have other sutures like metopic suture between the two frontal bones. But in adults we have four sutures. The coronal suture running horizontally from one side of the skull to the other across the skull, separating the frontal bones from the parietal bones, and the sagittal suture in the midline, vertical suture running, separating the two parietal bones from each other, and the rhamnoid suture situated at the back of the skull, separating the parietal bones, right and left, from the occipital bone, the squamous part of the occipital bone, and the squamous suture situated on each side of the skull, separating the parietal and temporal bones. So, four sutures, four main sutures: coronal, sagittal, rhamnoid, and squamous. The craniometric points, in the midline points and the lateral points. The midline points, as regards their importance, the most important point is the bregma, which is the intersection of the sagittal and coronal sutures. And it is the site of the anterior fontanelle in children, where it closes at the age of 18 months. And from here you can have a good idea about the intracranial pressure in infants. Also in the midline, posteriorly, is the lambda, which is the point of intersection of the sagittal and rhamnoid sutures. So sagittal and coronal, bregma. Sagittal and rhamnoid, lambda. Other points important is the nasion. For measurements, as we see, it is present at the root of the nose, and it is the intersection of the frontal bone and the two nasal bones. And the glabella, which is above the nasion, it is the most prominent part of the forehead between the eyebrows. And another point in the midline, the vertex, which is the highest point of the skull along the midline of the sagittal suture. So sagittal suture in the midline, highest point is the vertex, and the inion, which is the most prominent point on the external occipital protuberance present in the occipital bone, squamous part of the occipital bone, and it denotes the confluence of sinuses, which is the junction between the sagittal and transverse sinuses. The lateral craniometric points are the terion, which is the junction of four bones: frontal, parietal, temporal, and sphenoid, and is present in the anterior lateral skull base, and the asterion present in the posterior lateral skull base. It is the junction of three bones, parietal, occipital, and temporal bones. And we have also the supramastoid crest at the base of the mastoid. It's a very important landmark. It roughly denotes the site of the transverse sinus, which means that above this crest is the temporal fossa, or the middle fossa. Below it is the posterior fossa. So laterally, terion, asterion, supramastoid crest. This is a view of the skull from above, and it will show us some illustration showing what we are talking about. Here is the frontal bone. Here is the right and left parietal bones, and the suture separating the frontal from the parietal bones running horizontally is the coronal suture, and the suture running vertically separating the two parietal bones from each other is the sagittal suture. And posteriorly we have the lambdoid sutures separating the parietal bones from the squamous occipital bone, and the point of intersection of the coronal and sagittal is the bregma. Point of intersection of the sagittal and the lambdoid sutures is the lambda. If you have a lateral view of the skull, we'll find the lateral craniometric points. As we said, anteriorly is the terion, which is the junction of four bones: frontal bone, parietal bone, sphenoid bone, the greater wing of the sphenoid, and the squamous temporal bone. Sometimes, so here they meet, here frontal, parietal, squamous, and sphenoid. Point of intersection of the four bones, or the region, is called the terion. And posteriorly we have the junction or point of intersection between three bones which are the parietal bone, squamous temporal bone, and occipital bone, is called the asterion. So here is the terion, here is the asterion. Lambdoid suture, squamous, yes, squamous temporal, parietal, and squamous occipital. So this is the asterion, and this is the terion. The supramastoid crest, you notice here that supramastoid crest is at the level of the upper border of the zygomatic arch. So in people where the supramastoid crest is not well developed, you continue a line posterior along the upper border of the zygomatic arch, and we said this denotes the site of the transverse sinus. Above it is the middle fossa, below it is the posterior fossa. This is a view showing part of the skull in relation to the bone. This is the coronal suture, this is the superior temporal line, and this is the squamous temporal bone. The superior temporal line is a line not following the sutures present in the lateral view of the skull, and here is the superior temporal line. It's a very important line. You will know why later on. And if you see the skull from behind, you find the posterior part of the sagittal suture, the lambdoid suture. Intersection of the sagittal and lambdoid is the lambda. And also we have here the parietal bone, and squamous occipital bone. And if you go in the occipital bone, you find in the midline also the external occipital protuberance and the superior nuchal line, giving attachment to the cervical muscles, and below is the inferior nuchal line. Neurosurgical points other than the craniometric points. The key point or keyhole is important for the terional approach, which is a very important approach to the skull. And the keyhole You find it by many ways, but one of the easy ways is below and behind the lower end of the superior temporal line. It is present between the anterior and middle fossa and used for the exposure of the sylvian fissure. And also you can expose the orbit through the key point. So the key point is a very important point for a very important approach, the terional approach. Professor Dollens, Vinko Dollens, used to tell that there are three approaches to the skull: terional approach, callosal approach, and posterior fossa approach. So the terional approach is a very, very important approach, and the key for this approach is the keyhole, which is below and behind lower and superior temporal line. Also, one of the neurosurgical points, foramen of Monro, present midway between the bregma and the external auditory canal, as we'll see for the zero line in the application of external drains, and some points to enter the ventricles. Kocher's point, present anteriorly at the coronal suture or anterior to it, 2.5 centimeters from the midline. You hit the frontal horn, and you can consider it along the mid-pupillary line. Keen's point is another important point, lateral. It is 2.5 to 3 centimeters above the ear pinna and 2.5 to 3 centimeters behind the ear pinna, hitting the body of the lateral ventricle. And Frazier point is 3 to 4 centimeters of the midline, not 2.5, 3 to 4 centimeters, and 6 centimeters above the inion to the occipital horn, and the body from posterior. And last is the Dandy's point, which is no longer used. It is 2 centimeters lateral to the midline and just 3 centimeters above the inion, hitting the occipital horn, but it is no longer used because it can cause damage to the occipital lobe and affect vision. So we start by the key point. Here is the key point. Here is the superior temporal line, as we said. It ends here. So below and behind the lower end of the superior temporal line. Here is the lower end superior temporal line. We are behind it and below it, and it is above the zygomatic suture, and the keyhole is not the terion. It is anterior and below the terion. And then you extend your incision and make the frontotemporal or terional flap with many subtypes, mini terional, extended terional, as you wish. It's not here. We'll talk about it in approaches. And another view, the keyhole for the terional approach is below and behind the lower and superior temporal line. It is below and anterior to the terion. Another view, superior temporal line and the keyhole. Foramen of Monro is present midway between the bregma and the tragus of the ear. And so if this is the tragus of the ear and this is the bregma, and you divide midway the distance from here to here, approximately at the foramen of Monro. And this is of utmost importance for the application of the external drains. To the 0 point of the external drain should be at the level of Monro. As we said, it's midway between the bregma and the tragus, but some people put the 0 point at the level of the tragus of the ear itself, but it is lower than usual. So when you apply external drain, you see the bregma, you see the external auditory canal, half the distance between them is the level of the foramen of Monro. As I said, some put the 0 point at the level of the tragus, but it should be put midway between the bregma and the tragus, midway, bregma and tragus, midway between bregma and the external auditory canal, here. But you can put it at the level of the tragus, then you elevate your container distance from the 0 point, whether you want 10, 12, 15 centimeter water or millimeter mercury. And the other than the Keen point, we talk about Kocher's point, Coher's point. Where is Coher's point? Coher's point is a very important point present at the coronal suture or anterior to it by 1 centimeter or 2 centimeters, and it is 2.5 to 3 centimeters from the midline, as we said, and it hits the lateral ventricle. When you put a frontal shunt, I usually put my shunt tube proximal end in the frontal burr hole, 2.5 centimeters from the midline at the coronal suture, so you hit the ventricle even if it is a slit ventricle, or in cases of idiopathic intracranial hypertension, you can hit it easily. So it's a very stable landmark, and here again 2.5 to 3 centimeters from the midline in anterior or at the coronal suture. And Keen's point is another important point where you hit the body of the lateral ventricle, and it is, you see the ear pinna, you go above the ear pinna by 2.5 to 3 centimeters and behind the ear pinna by 2.5 to 3 centimeters, and then you apply your catheter perpendicular trajectory, somehow cephalic, and you reach CSF. And if you want to put your tube in the frontal horn, you can extend it to 7 centimeters to reach the frontal horn and to apply it there. So Keen's point, lateral aspect of the skull, 2.5 to 3 centimeters above, 2.5 3 centimeters behind the ear pinna. Keen's point. Coher's point, Keen's point, another. Coher's point is here, and Keen's point is here. And Frazier point is a posterior point. It is 6 centimeters above the inion and 3 to 4 centimeters off midline, because the ventricle, posterior part of the ventricle, is directed laterally, so it is not 2.5 centimeters to 3, but it is 3 to 4 centimeters of the midline, 6 centimeters above the inion. Again, 3 centimeters lateral to the inion and 6 centimeters above. Then this point is no longer used for risk of visual affection. It is like Frazier's point, but it is 3 centimeters only above the external occipital protuberance, and this can injure occipital lobe, causing visual affection. Craniocerebral relationship is another topic we are talking about. As we said, it's very important to know the surface anatomy of the central and sylvian fissures. So the central sulcus, was called also the Rolandic fissure, is the upper 2/3 of a line between the mid-zygomatic point and 2 centimeters behind midway from the nasion to the inion. If you see it, you will remember it very easily. So, where is the mid-zygomatic point is here, and the nasion is here, the inion is here. You calculate the distance from the nasion to the inion, and half the distance, 50%, you go behind it by 2 centimeters. And you connect this point with the mid-zygomatic point. We have a line. The upper 2/3 of the line is the central sulcus. Lower third is nothing. So, again, we'll see it. Maybe this is clearer. We measure the distance from the nasion to the inion, get 50% of the distance is here. Half the distance, you go posteriorly by 2 centimeters. This is the upper point, and the mid-zygomatic is the lower point. The upper 2/3 of this line, joining the 2 points, is the central sulcus. So what about the sylvian fissure or the lateral sulcus? It is a line extending from the outer canthus of the eye to 3/4 of the distance from the nasion to the inion. That's why you have to know where is the nasion and where is the inion. So again, this is the nasion, this is the inion, and this is 50% the distance. This is 75% the distance towards the inion. And you extend the line from the outer canthus from the mid-zygomatic point posteriorly to the junction of the 3/4 and 1/4 of the distance from the nision to the inion. You get the sylvian fissure. So, one last time, central sulcus is the upper 2/3 of a line joining the mid-zygomatic point with 2 centimeters behind midway from the nision to the inion. Sylvian fissure from the outer canthus to 3/4 of the distance between the nision and the inion. Of course, the frontal lobe, parietal lobe above the sylvian, temporal lobe is below the sylvian, and the central sulcus in front of it is the precentral gyrus having the motor area, and behind it is the post-central gyrus carrying sensory area 312. That's why it is very important to preserve the motor or cortical sensation, to know where is the central sulcus in relation to the brain. Surface anatomy, superior sagittal sinus and transverse sigmoid sinus. Of course, the superior sagittal sinus is in the midline, extending from the nasion to the inion. It is in the midline, it is below the sagittal suture, anteriorly, and continuing to the confluence of sinuses. Very easy. The transverse sinus is extending from the inion, as we said, which is the external occipital protuberance, to the point of intersection of the supramastoid crest and mid-mastoid line. So, before it forms the sigmoid sinus, as you know, the transverse sinus or the lateral sinus is a line from the inion to the supramastoid crest, and the intersection of the supramastoid crest with the mid-mastoid ends the lateral sulcus, becoming the sigmoid. So the supramastoid crest marks roughly the transverse sinus, and above the transverse sinus is the temporal region, above the supramastoid crest, and below it is the posterior fossa. And here is a view, and you see the zygomatic arch, and you see the supramastoid crest. Above it is the middle fossa, below it is the posterior fossa, and we said if the supramastoid crest is not apparent, it is continuation of the upper border of the zygomatic arch. So this is roughly the place of the transverse sinus. We have also a triangle called the suprameatal triangle, which is more of concern for the ENT surgeons. Suprameatal, external auditory canal, it is above the external auditory canal, and it is lower border of the zygomatic arch and anterior border, upper part of the external auditory canal, and the line in between, and it enters the mastoid antrum. So if anybody tells you the suprameatal triangle, this is the inferior temporal line, which is the line of the supramastoid crest. It's called also inferior temporal line, and this is suprameatal, above the meatus, triangle, along the posterior border of external auditory canal, lower border of zygomatic arch, and a line in between. There is a circuit which is not included in the anatomy. I am calling it the fabulous circle. It's for you to understand it, but actually in anatomy there is nothing called the fabulous circus, but the circle, but I am telling it for you so that you cannot forget it. It is a circle formed of the superior temporal line, posterior border of the zygoma, zygomatic arch, and supramastoid crest. Let's see again. So it's very obvious here, the supramastoid crest, as we said, and as we said, it is the continuation of the upper border of the zygomatic arch. So if you consider the superior temporal line then the zygomatic bone, then the upper border of the zygomatic arch, then the supramastoid crest, then the superior temporal line again. This is the circle I'm telling you, and this is the name I gave to the circle for its importance. It's nothing, it's called fabulous circle, just for you for teaching purposes. The lower end, superior temporal line, we have the keyhole here. If you want to go to the infratemporal fossa without opening the skull, you can reach it by removing part of the zygomatic arch, and of course the supramastoid crest, demarcating the site of the transverse sinus, and the junction of the supramastoid crest with the mid-zygomatic point is the point where the transverse makes the sigmoid. You remember we said that the transverse extends from the inion to the supramastoid crest, and the mid intersection of the mid-mastoid point with the supramastoid crest is where the transverse sinus ends and forms the sigmoid. So this is the circuit. The superior temporal line also, when you want to do a pterional approach and you don't want to expose much of the frontal lobe, the problem is in the sylvian fissure or temporal, you do the medial limit of the craniotomy along the superior temporal line. You don't have to do it through the pupillary line. If you want to expose more of the frontal lobe, you go to the mid-pupillary line, which is medial to the superior temporal line. This is one point. The keyhole is below and behind the lower end of superior temporal line. Another point. The zygoma is the lateral wall of the orbit, and you can open it and reach lateral orbital approach. The zygomatic arch can be removed, reaching the infratemporal fossa and the parapharyngeal fossa without opening, or with combination of pterional approach if you have a tumor like trigeminal schwannoma extending from the middle fossa to the infratemporal fossa, and the supramastoid crest separating posterior fossa from the middle fossa, which is important in opening and important in the posterior petrosal approach, and important in localizing where is the transverse sinus, where to put your burr hole. So if I have posterior fossa, I will open here. I have a middle fossa, I open here. Another, look here, supramastoid crest is not that obvious, so it is continuation of the upper border of the zygomatic arch. It is here. Here is middle fossa, here is posterior fossa. And where the transverse extends, it extends from the inion to the supramastoid crest till the mid-mastoid, then it becomes the sigmoid. So the transverse from the inion to the supramastoid crest. Above this, middle fossa, below this, posterior fossa. And as we said, fabulous circle, the keyhole, as we said, is related to the superior temporal line, as we said, exposing the frontal lobe, temporal lobe, superior and lateral wall. And if you need to expose just the pterion, as we said, you put the holes along the superior temporal line. If you need to expose more of the frontal lobe, put the burr holes medial to the mid-pupillary line, medial to the superior temporal line. And as we said, the zygomatic arch can reach the subtemporal fossa. That's why I'm calling it the fabulous circle. And this is to show you, this is the keyhole here, and this is mini pterional or classic pterional approach if you want. And also you can do anterior subtemporal approach or posterior subtemporal approach, knowing exactly where is the transverse in relation to supramastoid crest. And also, as we said, you reach the infratemporal and parapharyngeal fossa. You can remove the zygomatic arch with the pterion in case of cranio-orbizygomatic approach, which is a very famous approach, what we call COZ or mini COZ. You go down, remove the zygoma to see up. So for lesions in the interpeduncular fossa, up situated, you have to go down to see more of up. So we take out the zygoma with the pterion and with the zygomatic arch called cranio-orbizygomatic approach. As we said, the upper border zygomatic arch is at the level of supramastoid crest, and as we said, the supramastoid crest denotes roughly the site of the lateral sinus, and above the supramastoid crest is middle fossa, below it is posterior fossa. So here, to show you here the temporal fossa, and here is the infratemporal fossa, and medial to it is the parapharyngeal fossa. And here is the COZ, cranio-orbitozygomatic approach. You can remove it in one piece or in two pieces. When you take this bone too much from down, you can see too much up. So that's why lesions in the interpeduncular fossa, high suprasellar lesions, can be approached through this approach, which is modified form of the classic pterional. And again, the fabulous circle, you say it yourself. Yes. And here, and here, and here, and again. One of the signs when you do a lateral cerebellopontine angle approach, you find you localize the transverse sinus, as we said, at the supramastoid crest, and you line from it to the inion, and you find laterally some emissary veins in the bone. We are reaching, this is a sign that you are reaching almost the sigmoid. So always, when you do a posterior fossa approach, you extend your approach as up as the transverse and as lateral to the sigmoid sinus. And one of the signs you find before reaching the sigmoid, you get emissary veins from the bone draining into the sigmoid. This is a sign that you are approaching the sigmoid sinus. And we said, as we said, it is transverse is extending from the inion to the supramastoid crest, and the sigmoid is from the supramastoid crest to roughly the mid-mastoid point. And this is a case of a posterior petrosal approach where you open in the posterior fossa and the middle fossa, and as you know where is the transverse roughly, you put your burr holes above and below the transverse process here, and you combine it with the temporal region, what we call the pre-sigmoid subtemporal approach. Pre-sigmoid subtemporal approach is the posterior petrosal approach. So this is one of the approaches. You should know where is the transverse and sigmoid sinus. Thank you very much for your attention, and I hope we meet soon with the anatomy of the skull base to end the skull and start after that with the vertebral column, and hope to see you soon, and thank you very much for your attention.